Hello, everybody. I'm going to talk to you today about neuropharmacology. Pharmacology is sometimes considered a difficult science, but we still need to know a little bit about the principles behind the drugs we use and also the mechanisms of their actions. In this short talk, it's not possible to go through all the drugs used in neurology, but I will endeavor to give you some broad principles so that you can then structure your reading around it. You will also get some questions based on pharmacology in every subsection, including neurology. Now, basically, neuropharmacology is a branch which studies how drugs affect cellular function and also the neural mechanism by which they affect behavior. There are two branches mainly of neuropharmacology. One is behavioral and the other is molecular. Now, molecular neuropharmacology involves the study of neurons, the neurochemical interactions, the receptors on the neurons, and also about the neurotransmitters. We should need to have quite a good idea about neurotransmitters, particularly as they play a great role in management of some conditions, especially epilepsy and neuropsychiatric conditions. And also, once we get to understand molecular neuropharmacology, we will come to know about management of pain, neurodegenerative conditions, and psychological disorders. Now, first, we just look at some of the common neurotransmitters. The GABA system mediates synaptic inhibition, so it's an inhibitory neurotransmitter. It's released from the presynaptic cells. It then binds to a receptor. They're GABA A receptors and GABA B receptors, and they cause a postsynaptic cell to hyperpolarize, and it stays below its action potential threshold, and this counteracts the effect of any excitatory manipulation and hence its inhibitory effect. Now, GABA A receptors contain many binding sites which allow for conformational changes and is also a primary target for drug developers. One common drug that we can know about acting on the GABA A receptors is benzodiazepines. Likewise, another receptor is called the GABA B receptor, which can be enhanced by a molecule called baclofen, which is used for treatment of spasticity. The other neurotransmitter that you should know about is dopamine, which mediates synaptic transmission by binding to 5 specific receptor sites, separated into various classes, and there are many drugs that affect dopamine and its interactions with the brain. In Parkinson's disease, there's a decrease in the amount of dopamine, and hence we have to give dopamine orally, but for it to cross the blood-brain barrier, dopamine has to be added on to a transporter, and we'll talk about that a little later. There are also dopamine agonists which are given because levodopa in the long term was associated with side effects, and so this led to the development of dopamine agonists. And the two that are common use in the UK were ropinirole and pramipexole. We also use rotigotine patches, and when we cover Parkinson's disease, you'll come to know more about them. Psychological disorders like ADHD can be treated with drugs like Ritalin, which block the reuptake of dopamine by the presynaptic cell, and so the amount of dopamine that's left in the synaptic cleft increases. There are, of course, illegal drugs such as cocaine also mediate the dopamine neurotransmitter. Then there is serotonin, which is basically has the ability to mediate synaptic transmission through receptors. The excitatory or inhibitory postsynaptic effects of serotonin are determined by the type of receptor in the given brain region. And there you would have heard of SSRIs, which is the selective serotonin reuptake inhibitor, and these are used a lot in the treatment of depression, and they inhibit the reuptake in the presynaptic neurons. Before the SSRIs, we used to use the MAO inhibitors. They're less commonly used now because they ended up giving a lot of side effects, especially migraines and high blood pressure. And so we have now the SSRI. more commonly in use. You also should know something about the ion channels. There are channels which allow the influx of sodium ions and outward movement of potassium during an action potential, and by blocking these selectively, it will decrease the likelihood of an action potential to occur. Now, one of the drugs that we use for motor neuron disease, it's perhaps not that effective, and in fact, research has only shown that it delays time to tube of any kind, which is in a progressive case, a case of MND which has progressive symptoms, is a maximum of 3 months. So its effect is somewhat dubious, but it's a sodium channel blocker, and this drug is in use. Perhaps the only drug at the moment, though some new drugs have been recently approved by the FDA. Now, this was about molecular neuropharmacology. Behavioral neuropharmacology, on the other hand, studies how various medication affect behavior. These are medication used for mental health, such as antidepressants and antipsychotics. And then they have the hypnotics. Then you have recreational drugs, and of course, alcohol also comes under this cover. I'll talk about a few specific conditions, as it's extremely important to know about these. One is the anti-epileptic medication. Now, epilepsy started getting treated in the late 1800s with bromides. They weren't very useful. Phenobarbital then came in as the drug that was used to treat epilepsy. And then there was a development of other anti-epileptics, phenytoin, which is still one of the gold standard drugs, and perhaps it's right to term it as a miracle drug, along with digitalis, penicillin, and insulin. These are drugs that have revolutionized treatment of various conditions for which they use. Phenytoin is still used worldwide, and is still a popular drug, especially in treatment of seizures in the acute setting. As it's it's one of the readily available parenteral formulations. There are other medication. The first lot or sometimes some neurologists term them as first-line anti-epileptics is phenytoin, carbamazepine, and sodium valproate, and they still enjoy widespread use. Subsequently, we have lamotrigine, topiramate, zonisamide, and of course, perhaps I would term this as the new miracle drug as levetiracetam, and now, of course, we have a new derivative called brivacetam. We also have 𝑨𝒃𝒂𝒓𝒛, tiagabine, and the list continues to grow, and many new anti-epileptics are available. It's beyond the scope of this talk to go into any specific anti-epileptics, but there are a few specific considerations that I would like to talk to you about. There are certain drugs which are specific to certain conditions. Therefore, I mean, if you have focal epilepsy, then perhaps carbamazepine is a better drug of choice, but you would avoid it in myoclonic epilepsy, as it's known to worsen myoclonic epilepsy, and certainly in a condition of juvenile myoclonic epilepsy, carbamazepine is to be avoided. On the other hand, for generalized seizures, you might find a patient coming to you with phenytoin because it was administered in an acute setting, but usually we tend to convert the patients on to either lamotrigine, levetiracetam, or sodium valproate if it's safe. We need to know that sodium valproate has the maximum teratogenic risk, especially in neural tube defects, and has been associated with conditions such as open spina bifida. We have in the UK set down guidelines from the government where a patient has to be counseled about the use of sodium valproate, the potential side effects. They have to be handed over a booklet, and they have to sign an annual risk assessment form where the clinician has to certify that we are using sodium valproate, as this perhaps is the only drug effective in the condition, and likewise the patient has to certify that they've been made aware of all the potential risks involved in using it. We tailor our therapy according to the seizure type, and then we see which drug is effective. We start low and then build up slowly until we reach a therapeutic effect of the drug. Of course, there are the BNF, which is the British National Formulary, and all of you should be familiar with it. It's available online. It does clearly indicate the upper limit of medication, and we try and settle patients before we reach the upper limit of medication to avoid side effects. If one drug is not effective, then we add on an anti-epileptic, or sometimes we try to change over, as monotherapy is always considered better than polytherapy, but there are patients who may need even more than 2 medication to settle their seizures. Rational polypharmacy is the use of anti-epileptic medication in a rational way, keeping the age. Certain drugs are to be avoided in elderly people, and certainly for old age people, we would only use either levetiracetam or lamotrigine after certainly 70 years of age, as they have lesser side effects. Likewise, if we have a young woman, we would probably, our drug of choice would be levetiracetam, lamotrigine, or carbamazepine. We have to counsel the patients and document that we have counseled the patients about the potential teratogenic effects of the medication. And once again, if a patient is pregnant and is on a medication that may be potentially more teratogenic, we try to switch over to a less teratogenic medication if the patient is agreeable to that. There are special conditions such as learning disabilities. There are patients who are not able to take their medicines orally, and then we have to try liquid preparations. There are patients who are on a PEG-fed, which is a tube which is for feeding tube, and so medication has to be administered, and therefore we have to use preparations which can be pushed in through the PEG tube. Patients need to be monitored while on medication, and therefore they're generally under the care of a consultant or an epilepsy nurse. We don't do regular blood tests unless there is, and that is not recommended unless there are special indications for the same. But it may be remembered that the drugs are potentially hepatotoxic and have to be used with great caution, especially in settings of either hepatic failure or kidney failure. And once again, a ready reference which would be available to all of you will be the BNF, and you can always refer to it. And every special consideration, including renal failure, breastfeeding, pregnancy, etc., are well mentioned, and including the potential side effects of medication. Status epilepticus is a complication of epilepsy where a patient will present with intractable seizures. The management of this is fairly standardized and laid down. We always look at the ABC, which is secure the airway, check the breathing, ensures the circulation, and have an IV line in. So securing the airway is extremely important. If the airway is threatened, patients selectively intubated at least for 24 to 48 hours. As a first line, we use benzodiazepines. Drug of choice is lorazepam, but we use diazepam as well. In primary care settings, diazepam can be administered rectally as well, and patients who are in care homes and other facilities, we train the carers as well as the family members to use buccal midazolam. Phenytoin injectable as well as levetiracetam are used. Sodium valproate is also available as an injectable, and if the patient does not respond to this, we put them on a midazolam drip, or we use anesthetic agents such as propofol to control seizures, and once they're seizure free for a period of time, then we slowly wean them off and bring them on to oral medication as soon as possible. Now, movement disorders are at the moment very manageable with neuropharmacology. Essential tremors are treated with beta blockers. Generally, they show a good response. If the patient has no asthma, COPD, peripheral vascular disease, or any other contraindication for its use, we also use primidone, and in rare cases trihexyphenidyl, as it does have more severe side effects. Parkinson's disease treatment will be we'll talk about it when we cover Parkinson's disease, but the gold standard drug is levodopa. There was some controversy in the 80s about whether it should be started early or late. There are some schools of thought that advocate using levodopa at an early date, as it's an effective treatment, and certainly gives the patient a better quality of life. Much younger patients presenting in their 40s and early 50s, we would tend to use a dopamine agonist such as ropinirole or pramipexole. and we have to counsel them. We have to tell them of the side effects, as dopamine also works on the pleasure circuits in the brain, and patients have been known to show hypersexual behavior, as well as pathological gambling and ICDs, which is impulse control disorders, with dopamine agonists. And then if this is reported, then patients are immediately taken off this medication. Levodopa, it doesn't cross the blood-brain barriers, so we use either dopamine decarboxylase inhibitors, which is preparations such as carbidopa or benserazide, and levodopa is started again in a small dose, and we build it up gradually, counseling the patient about side effects, and we monitor them on this medication as they get along. There are also drugs called an enzyme preparation called 𝒃𝒂𝒛, which sometimes is very useful, as if the patient starts developing dyskinesias, which is an excess of dopamine in the system, and they get dancing movements of their limbs, we will either reduce the dose of levodopa by adding some 𝒃𝒂𝒛, or we put them on a dopamine agonist to cut down the effects of levodopa if it's in excess, and try and balance the situation. There are side effects, of course, of this medication. The patients can develop some hallucinations and GI side effects. Likewise, they can get dyskinesias. Some people get an intense craving for levodopa, and they seek prescription, and they go to various sources and take enormous amounts of levodopa, and this is called the dopamine dysregulation system, and we have to gradually wean them off. Dopamine cannot be suddenly stopped under any condition, as there's always a risk of them developing excuse me, the neuroleptic malignant syndrome, which can present with high fever, muscle stiffness, raised CK levels, and leukocytosis, and these patients are treated by reintroducing dopamine into the system. Myasthenia gravis is another condition which is eminently treatable. It's we have to understand the pathology, where there's the receptor size for acetylcholine. The receptors get lesser in number and also be blocked by acetylcholine receptor antibodies. Also, the circulating amount of acetylcholine decreases, and so we use pyridostigmine to increase the availability of acetylcholine. In acute situations, we can use neostigmine. We have to always watch out for cholinergic effects, as this can increase diarrhea, abdominal cramps, tearing. Sometimes steroids may be required as the condition advances. Steroids can cause a paradoxical worsening of myasthenia, so we have to be extremely careful, and we have to start on a very small dose. The cornerstone of treatment, the key to treatment is immune suppression. We do a scan in these patients and look for a thymoma, and if there is a presence of a thymoma, they undergo a thymectomy, and we immune suppress the patients initially with steroids, but usually add either azathioprine, mycophenolate, and even biologicals such as rituximab. Now, a myasthenic crisis is a dreaded complication. Likewise, after securing the airway and making sure that we have a line in, we initially will stop the pyridostigmine in case it's patients on pyridostigmine, because we don't know if it's a cholinergic or a myasthenic crisis. The patient would be quite acutely ill. We usually give intravenous immunoglobulins or steroids. We also give pyridostigmine, reintroduce it, and then, of course, take them back on the standard lines of treatment. And if there's any intercurrent infection that needs treating, bring them onto oral meds as soon as possible, and then monitor them closely. GB syndrome, which is Guillain-Barré, also called the acute inflammatory demyelinating polyneuropathy, can present with an ascending flaccid paralysis with areflexia. It can have some sensory symptoms, so please remember that it's not always pure motor. And the patient, likewise, once we've secured the airway and ensured that the patient's saturations are maintained, we use immunoglobulins, monitor the patient. If there's not an adequate response after a 2-week wait, because we don't want to wash out the immunoglobulins, we can try plasmapheresis or another course of immunoglobulins, and then, of course, they need intense rehabilitation. Patients can develop chronic demyelinating neuropathies, and such as CIDP, which is chronic inflammatory demyelinating polyneuropathy, and other demyelinating neuropathies. They are generally treated with long-term steroids or pulsed immunoglobulins in every 4, 6, 8 weeks, depending on the cycles we set up for patients, and they come in daycare units and get this. They're also the role for immunosuppression in such patients. So what is IVIG? IVIG is intravenous immunoglobulin. It's a pooled antibody preparation. It's fairly expensive, so it has to be used with caution. There is an IVIG panel, so whichever request we put up, including in emergency situations in the UK, it is passed through an IVIG panel, and the patient gets a national number because if they're to be put on long-term preparations. It has widespread applications. It's used to normalize a compromised immune system. The basis of IVIG is 90% is IgG. It's used in immune deficiency states as replacement for immunomodulatory effects and the inflammatory effects such as in GB syndrome. The other name for it, as I told you, was AIDP. Generally in AIDP, myasthenic crisis, we use IVIGs. The first thing to do is to exclude IgA deficiency, as this can present with acute anaphylaxis if the patient has an IgA deficiency and we use IVIG without testing. The mechanism of action is complex. It binds and neutralizes circulating autoantibodies, and it also works on cellular immunity and cytokines. It does have adverse effects, particularly thrombotic complications, and the kidney function needs monitoring. MS is again treated in two ways. So one is, of course, the acute relapse. We must recognize what's a relapse and what are non-relapse symptoms. Patients given pulsed steroids according to the NICE guidelines, the National Institute of Clinical Excellence, and pulse steroids are methylprednisolone 1 gram daily with stomach and bone protection for 3 days, or 500 milligrams orally for 5 days. Usually the effects are seen either immediately over the next few weeks. DMTs is disease-modifying treatments. We only use them in patients with relapsing remitting MS at the moment. There are some trials with one of the biologicals in secondary progressive MS. Usually the rule of thumb is more than 2 relapses in a year, or if the neuroimaging shows a very heavy lesion burden. The injectable preparations are the interferons, glatiramer, and of course one of the Zumabs, and then they are oral medications such as teriflunomide, monomethyl fumarate, dimethyl fumarate, fingolimod, cladribine, and siponimod. The list is widening, and the biologicals are developing very quickly, so one has to be alert and aware of these and also their major side effects. These drugs are only prescribed by an MS specialist, which is a neurologist with special training in MS, has specialized centers monitored under MS nurses, and has revolutionized the treatment of MS. There are infused medication as well, such as alemtuzumab and mitoxantrone, which is not so much in use, ocrelizumab and natalizumab tisabri, which is used in patients with very, very severe MS and very heavy burden. Now, finally, just before I close, how do we name biologicals? This has been quite confusing, and it's interesting to know how they're named. The WHO had set some rules for developing biologicals, and they usually end in MAB, MIB, or NIB. To decode them, there is some rules have been set. The first thing is you need to know, this is a busy slide, but you can go through it on your own. These are the stems and how the nomenclature is developed. And then, of course, say you take a MAB stem, which is basically denotes a monoclonal antibody. There is a segment 1, segment 2, and segment 3. You can read this on your own. But this would probably, if you take one example, you will understand how biologicals are named. We take a monoclonal antibody such as denosumab and apply the rule. So denu is the distinctive prefix. This is the developer's got a liberty of naming this. 2 stands for tumor. T is tumor, but U is added for ease of pronunciation. Z means a chimeric, which means 2/3 human and 1/3 mouse. MAB means class of drug, which is a monoclonal antibody. So that's how biologicals are named. It's quite interesting, and maybe you'll get to read about it. That's all I have to share with you today. Do read and read around the conditions. That's the best way to learn about neuropharmacology. And if you get some time, we will discuss some questions related to this at the live session. Thank you.